Thank you, Mike. Good morning, everyone. Thank you for this opportunity to present our early work on the new transcleral cyclophotocoagulation. And I would like to apologize on behalf of Professor Paul Chu. He really planned to come here, but due to health problems, he was unable to fly to US. Okay. I have no financial interest in Iridex or in the rest of the probes that you will see. And to start with the micropulse laser technology, the delivery of the diode laser irradiation in micropulses has been known to be effective in achieving selected and targeted laser to the tissue. And this is also minimal collateral tissue damage. And this has been proven effective in photocoagulation of retina cases. We all know that ciliary body ablation is an accepted mode of treatment, especially for cases of refractory glaucoma. And the common technique that we employ usually is a diode laser transcleral CPC. But even if this is better than than cryoablation, it still has its significant side effects. That is why our team, headed by Professor, had explored the idea of applying micropulse technique into cyclophotocoagulation. Just to, I know that everyone is aware of the laser pulses delivered by the two different types of laser. If you have a continuous wave, then you deliver a continuous strain of high energy, laser energy per pulse in the duration that you have chosen. But in a micropulse mode, the train of pulses is divided into repetitive small and short pulses, where there is an on period for the laser to fire and an off or rest period for the laser to be off. And just to show you how the computation for the effective duty cycle and the pulses per second, if you take an exposure duration of 200 milliseconds, it envelopes about 100 micropulses with a period of 2 milliseconds. In each 2 millisecond period, the laser is on for about 300 microseconds, and it's off for about 1,700 microseconds. If we base the calculation from this duration, then the duty cycle that we get is about 15% with the 500 pulse per second repetition rate. So these are the probes. The one on the left is you're more familiar with, is a G probe. And this is the one that we usually employ with the continuous wave CPC. And the one on the right is the customized probe for micropulse cyclophotocoagulation. We did an experiment using these two probes. We fired the G probe into a matte cardboard, and then with the standardized setting of about 2 seconds. And we captured the temperature generated around the probe by a thermographic camera. And as you can see, you can see from this graph, the temperature generated by the conventional, the continuous wave G probe, it reaches about greater than 550 degrees centigrade. And the micropulse CPC probe, the one that we use to deliver micropulses, the maximum temperature generated was 35 degrees centigrade. And here is the technique that we use in order to deliver micropulses during cyclophotocoagulation. This is using the customized micropulse probe. So the technique is just to, instead of applying the laser as we usually do with the G probe, you apply it individually. This one is just to slide it just to slide it in a painting fashion. In the duration, the duration that we have found effective is about 100 seconds. The total treatment, both the superior inferior quadrant, avoiding the 3 and 9 o'clock. So these are the two versions now. We started with the version 1 of the probe. As you can see, it has a more concave surface. In the version 2, the tip has a more of a convex surface. What is the reason for this changing of the surface of the tip of the probe? Well, we had experienced that in the earlier version, there are certain situations where the conjunctiva is caught as you move the probe around. No, so but that's easy to remedy. You just release it and reapply the probe again, and then slide it again. But if the conjunctiva is chemotic, if the eye is chemotic, I mean, then it may be a little bit difficult. That's why with the new probe, we had experience with the version 2 that it's easier to slide. It's easier to, this is a video showing, you can see that this eye is very chemotic. Sorry, just a second. This is using, so you can see the eye is very chemotic. You can, come on, play. You can still easily slide it without being hampered by the conjunctiva. So what we did in our, so the concept, we started to do a pilot, we had a pilot study that was done around 2007, and it was published in 2010. In this pilot study, there were 40 eyes of 35 patients with refractory glaucoma, and the mean follow-up was 16 months to about 20 plus. The overall success rate for this pilot project was about 72.7% after a mean of 1.3 treatment session. And the outcome measure that was used for the pilot project was a greater than 30% reduction from baseline, or an IOP of less than 21. In this pilot, all these patients, all these eyes, 40 eyes, there were no major complications encountered. So we followed it up after 2010, after publishing it in 2010 in Clinical and Experimental Ophthalmology. We did a comparison exploratory study. So we compared the micropulse delivery mode versus the continuous wave delivery mode in transscleral diode cyclophotocoagulation. So this is a single center randomized exploratory study. We involved 48 patients with refractory end-stage glaucoma, and the outcome measures that we use this time is an eye pressure of IOP between 6 to 21, and at least, it's not and or, and at least 30% reduction at the final follow-up with or without the glaucoma medications. The secondary outcome measures were complication rates and the number of medications and repeat treatment. So the inclusion criteria, all these patients had refractory glaucoma, which was defined as an IOP of greater than 21 on maximum tolerated medical therapy with or without previous surgical intervention. And the best corrected vision was 660 or worse on Snellens. And those who refuse to or are poor candidates for glaucoma filtration surgery or drainage device were also taken into consideration for inclusion. The minimum follow-up is about 12 months and the maximum is 18 months. So the exclusion criteria, any previous CPC in the eye, any intraocular surgery within 2 months of enrollment, significant scleral thinning of more than 3 clock hours, patients who refuse to give the informed consents, and especially patients who refuse retreatment. So these are the settings that we used for this comparison. For the conventional CPC, we use a power of 1.5 to 2 watts, duration of 2 seconds per pulse, and about 270 degrees treated, with an average of about 20 to 28 pulses per eye, delivering about 60 to 112 joules per treatment. So the treatment energy may vary depending on the titration of the eye's response. If we hear a pop, we decrease the power in the energy of the laser. If not, then so that's what we followed during the course of the treatment. For the micropulse CPC settings, this is more or less, it's a standardized constant treatment. We use in all patients the power of 2 watts with 100 seconds pulse envelope, and the setting is for about 0.5 millisecond, the laser is on, so the laser is firing, and for about 1.1 milliseconds, the laser will be off. And as a technique, I've shown you the technique. It's a continuous painting technique over 360 degrees, sparing the 3 and the 9 o'clock meridians. And this constantly delivers about 62.6 joules in the whole duration of treatment. So we had 48 patients, 24 eyes were randomized to the conventional arm or the continuous wave, and the micropulse arm had 24 eyes too. There was no difference in the demographic characteristics of the subjects enrolled, and as well as the baseline eye pressure. The baseline, this is the baseline mean IOP. In both groups, it's 35, and it's 35 millimeters mercury on the conventional arm and 36.5 in the micropulse arm. The range actually, the one on the conventional arm, the IOP ranges from 22 to 58, and the one on the micropulse arm, it ranged from about 22 to 73. So baseline medications, the mean is about 2 for both, and the mean number of treatment for the continuous wave is about 1.8, and that of the micropulse arm is about 1.6. So the results show that at 12 months, the IOP, mean IOP lowering, the mean IOP recorded was 20 millimeters for the conventional arm, and for the micropulse arm is about 18 millimeters mercury. At 18 months, it was 19, and it was 20 on the micropulse. The IOP reduction was 45% for both of these treated groups, and the final number of medications about an average of 1. So with the statistical analysis showed that at 12 months, following the primary outcome that I have mentioned before, an IOP of 6 to 21 strictly, and a 30% reduction, we had a significant difference in success. For the continuous wave, it's 29% in 12 months, and for the micropulse, it's 75%. And at 18 months, there is a 30% success in the continuous wave and about 52% success in the micropulse. But this did not reach any statistical significance. As I mentioned, IOP reduction is about 45% in both groups, but also they are not statistically significant. The prolonged hypotony, we define this as an eye pressure of 5 and lower. We had about 5 treated eyes on the continuous wave, none on the micropulse. Nobody had a pressure of about 5 or lower. And just to mention, sorry, again, the 5 treated eyes that had hypotony, the majority of these cases are, of course, NVG with one silicone oil glaucoma, the diagnosis of the patients that had suffered hypotony. Now, just to show the difference between the individual IOP measures before and after treatment, we looked at the variance between the IOP recorded before and after treatment for both groups, and we put it in a scatter plot. And we found that in the MicroPulse treated group, the IOPs actually followed a close clustering in a straight line compared to the more scattered widespread of measures in the conventional technique at 18 months. And in the same manner, the Kaplan-Meier survival analysis for 18 months follow-up was also, it also favored MicroPulse CPC. And the outcome, one of the outcome measures, secondary outcome measures are the complications encountered. And there is a significant difference in the number of complications in the treated groups. The MicroPulse treated group has about 88% without any complications at all. And while that of the continuous wave had about 40% that had no complications at all. It was noted that the MicroPulse, the continuous wave had more prolonged inflammation, and we had one phthisis in the continuous wave, phthisis bulbi, and then there are 4 scleral thinning in continuous wave and 2 visual acuity decline in the continuous wave CPC. Now, regarding the number of treatment, there was no significant difference in the number of treatment between the MicroPulse and the continuous wave. And the number of medicines, there are also no significant difference between the two. So, in conclusion, the two techniques actually of diode laser delivery, whether it's MicroPulse or continuous wave, CPC, demonstrated an efficient IOP reduction from baseline. The difference is that the MicroPulse mode provided a more consistent and more predictable effect in lowering IOP with minimal complications. Possible advantages over conventional cyclophotocoagulation of the MicroPulse mode is that in the first stage, you can already appreciate a change in eye pressure, in intraocular pressure, and it has a better safety profile as what we think that there's less collateral damage due to thermal localization. The study that we had, it's limited by the small sample size of each group, and we hope that we could have follow them up longer than 18 months so that we can see what happens afterwards. And it is very difficult to mask the investigator to the type of treatment, but we have masked the subjects to the type of treatment. And another thing is, it's very difficult also to standardize because there's no standard protocol for the continuous wave cyclophotocoagulation. So that may be one reason why we have some variable results in the continuous wave as compared to the MicroPulse CPC, where there is always a constant level of energy that you delivered into the tissue. We tried to look at the possible mechanism and why for the efficacy or the response into the treatment. And we imaged a couple of patients before and after laser treatment. In some of them, we find no significant change in the ciliary body contour, but in a few of them, there is some thickening in the pars plana area, and in some in the pars plana and the pars plicata area. We also had the opportunity to find out. We treated one live pig's eye and with the micropulse technique, and the other eye was left untreated, and we sent it for histopath. And this is what we got. The lacy pattern of the ciliary body in the region of the pars plicata was maintained in both, whether it's treated or untreated. The difference is just in the pars plana area, as you can see from this side. There's a thickening and changes, tissue changes in the pars plana area. This is just to show you the untreated. This time is a human eye. The untreated and the conventional TCP and the micropulse TCP showing in the region of the pars plicata. Showing, we can see from here that the integrity of the pars plicata was maintained after treatment. We are still unclear. It's still unclear to us the exact mechanism. We can only hypothesize whether we may be opening channels of the uveoscleral pathway because of the non-lethal thermal energy delivered to the tissues. But the definite mechanism, we can say for sure how it works. So in summary, the micropulse cyclophotocoagulation, it has equal efficacy in terms of IOP lowering compared to conventional CPC. But the possible advantages is the rapidity of IOP drop, a better safety profile, and the non-destructive nature of the procedure. What is next? I heard that several investigator sites are currently using this technology, and early results are said to be encouraging. And we are slowly entertaining the concept of performing TSCPC in the earlier stages of glaucoma. Thank you for your attention.
Thank you very much, Dr. Aquino. If there are any questions, and let me hook up Dr. Aquino here. So you can hear the question.
Okay.
Thank you. What a lovely presentation. My question is, in the subset of the population who had the micropulse, 30% needed more than one micropulse to achieve the sustainable pressure with a 30% drop. At what point in time do you find it necessary to repeat the micropulse laser? How far out from the original procedure did most of the 30% of this population need to be done? Was it 6 months, 12 months, weeks? What was the average?
Yes. In the series of micropulse treated subjects, we started the repeat treatment was done on the second month. So, but the interval, we have seen changes in the eye pressure. So the interval of repeat treatment, we had repeat treatment at second month that's the range, to 6 months and 12 months.
And the third treatment, did you also wait 2 months after the second to see that you didn't get a significantly lower pressure, and then you repeated? So by 2 month intervals, and the most you repeated it was 3 times.
Yes.
And did you block each time in a retrobulbar or a peribulbar block for this procedure? And is this done in the office, or do you do this in the operating room?
We did this in the office.
In the office. And so the laser treatment is not an operating room procedure here.
We try to assess our patients if there are risks regarding the medical condition of the patient, then we put them and monitor in the operating room. But for those that are not at risk for any medical condition, majority of those cases that were treated in the office.
That's very interesting. I have another question. In the percentage of your population where the mean started out at about 36, but obviously the range went up to 70 millimeters of mercury, you
Yeah.
mentioned, did you find the need to do a paracentesis immediately after the procedure when the pressure was very high? Or how did you manage the pressure, and what did you see basically the next day? Do you anticipate an immediate drop in pressure, or do you expect a slower drop? And how do you handle the high pressures immediately after?
In the majority of the cases, those that had very high 40 pressures and above, they are on maximum meds already, multiple maximum meds. And immediately after, in most of them, the following day, you can already elicit a change.
So you expect in the majority of patients, regardless of their pressure the very next day, to see a substantial lowering of the intraocular pressure?
That was the experience that we had from treating those patients with 40 millimeter mercury and higher. Although you won't, of course, you won't reach a target of 21 immediately, but some of them had a response immediately, day one of the post-op follow-up. It registered already a response from the laser.
And in those patients who had very high intraocular pressures, who were on maximum therapy, and you started seeing a decrease in pressure, over what period of time do you start taking away the medicines rather than keeping them on their full dose schedule? At what point do you start pulling back?
In our experience, we keep them on medicines until the time that they come for a follow-up after a month. And then when we see that the pressure has gone down to the target range that we had, then we can start to pull one medicine at a time. But if not, then we keep them on their drops until we do a repeat treatment and find out whether the repeat treatment will allow us to reach a target, our target pressure for the patient.
Initially, when you see these patients and they are obviously coming to you for pressure control, when you consent them, do you say up front that they may need more than one of these to achieve a goal? Or is that part of your consent process?
Yes, we tell them that they may need 1, 2, 3 treatment.
Any other questions? All right. Thank you very much. This concludes this presentation.